be over here. Oh, I love
Sharing is caring. We can share the microphone. That's okay.
Follow your leader here, boys.
Okay. Hey, everyone. Thank you for sticking around to the end of day 2. And what this panel is all about is how can we as clinicians better communicate with other clinicians, other healthcare professionals, fitness professionals, Pilates, yoga, massage. How can we use what we know about a biopsychosocial model of care and be able to explain that and be able to communicate that with someone who may not be as familiar or who may be a little resistant to some of those concepts. And in coming up with this panel, we kind of took to social media and we asked people if they had had any situations in which they were at a loss. They didn't know what to do. They didn't know how to communicate properly with another professional. And so what we're going to do for this panel is we're going to start with a couple of scenarios and then get each of their take of all of the panelists, each of their take on what they would do in that situation. And we want this to be as interactive as possible. So we'll kind of get their views, and then if anyone had a sort of a similar scenario and you did something that really worked, then raise your hand and let us know so that we can share it with the group. Okay, ready? I don't feel like I have to introduce all of you again, right?
No, we can get right to the questions.
Okay.
We're ready.
Okay, great. So the first scenario is if you are, let's say, a student or you're a new grad and you are working in a clinic or in a gym or in whatever setting that you're in, and it is more of a biomechanical atmosphere, meaning the owner is, already got it, okay. So meaning that, the person who owns the clinic or who owns the gym, they know what they know, they're confident in what they know works, so why would they change? It's one of those places, as a PT, might be a little cookie cutter where the patient comes in and they get 20 minutes with the PT or PTA, 20 minutes with the assistant, and then 20 minutes on modality. And the owner says, well, everybody loves coming here, and I get complex patients, and look at how good I am. I've been open for 30 years. And they don't incorporate any of a pain science. They don't incorporate that biopsychosocial model of care. So the question for the panel is, what would you say to that new grad or to that person who's working for someone? Because the hard part there is you want to, I hope, keep your job. You don't want to be fired, yet you want to be able to do what's best and what's evidence-based and what's going to hopefully work best for those complex patients. So, Jason, why don't you start, and what advice would you give to a person in that situation?
Well, thanks for the question. This is a really challenging situation depending on the role that you're in. I would say that if you are a student and you're in a clinic that you feel is maybe a little bit behind the times when it comes to their treatment and therapy delivery model, maybe one that is a little bit focused on the kind of biomechanical things that are often full of nocebo and threat for our patients and don't often lead to positive things. I think it's sometimes important to step back and realize that as a student, you've got a lot to learn about a lot of things. And even clinics that don't do some of those things well, like maybe they focus too much on discs or facet joints or labrums or those sorts of things, you can learn a lot from skilled clinicians in that center about other things that they do, ways that they communicate with patients, how they frame their treatments, and how they move people through that episode of care. You also need to realize, I think, that it's helpful to learn about some things that aren't so good so you can appreciate some of the things that are good later on. And being able to compare different scenarios, different experiences that you've had, is a very powerful thing. I think if you're a new grad and you find yourself in a physical therapy mill, which is kind of the expression we sometimes use for those things to kind of move people across the conveyor belt, you probably made a serious error in your job selection algorithm at some point, and I think you need to make sure that you're having enough time in that place to get a solid experience there and be prepared to move on when you can.
Okay. Yeah, go ahead. So Nick, how would you handle that, or tell someone, because outside of a PT clinic, but let's say within the fitness realm?
Yeah, so I recently had a question. A guy, it was a trainer I was teaching at a conference, myself and another guy held in Orlando last weekend, and this trainer, young guy, just got his first NBA client, so his first pro athlete, and that could be a launching pad to get more clients in your area. And he said that he emailed me prior to it, and he basically said that their team strength coach has been working with another well-known strength coach, and they recommend he use PRI stuff, posture restoration, and how would I deal with that specifically. So, now he could confuse this athlete, and then the athlete doesn't, So first off, you got to go along to get along, or you don't get in where you don't fit in. You've heard all these sayings before, so you can't just go punch someone in the face with facts. I would say well, let me say, and when this is Exhibit A right here, that my dad used to tell me, he said, because I don't like bullies, and I've always been a shorter guy, but I was a good wrestler, and I'd take you down and drop you on your shoulder really quick. And he used to tell me, so you can't go around, if you go around punching every asshole, you become the biggest asshole. And that's kind of what happens with the debunking type thing. So I would say my answer to most of the questions, because we kind of talked about these outside of it, is going to be that what I've found is that there's a premise that certain people in this room are starting with that other people are not. So we all say it's an art and a science, right? But our interpretation of what science is very different. For example, science to this crowd is kind of a skeptical-minded way of thinking. It's null hypothesis. How much do you value evidence? Other professionals have not been taught that. They value anecdotal experience more. They value practical experience from experts more. And so the whole idea of this pain science right there, as soon as you start bringing that up, they're going to go, well, I don't care what that systematic review says. I don't care what that says. All I know is I've been doing this for 20 years, and my mentor was doing it for 35 years. So the discussion that has to be had prior to most of these other discussions, unfortunately, is why don't you value scientific evidence? Because that's what it normally comes down to. And then why do you have this? Because you hear those same arguments over and over again that are normally, everybody thinks they have the drop-dead argument against scientific evidence, right? Although those researchers aren't clinicians, you've heard it. Science doesn't know everything. Science is changing. First they said eggs were bad, then they said eggs were good. And those are all pretty crappy arguments. But until you establish those, you're not going to move ahead forward, because you're not going to score any points with someone who's playing on a different court. So I know that's not a direct answer, but it's a larger answer. You have to have that discussion first to understand how you can talk on the same level and you're not talking past people, because that's what a lot of us have ended up doing. So I don't want to soapbox anymore.
I thought that. And Jonathan, I think you covered a lot of that in your talk today. So do you have anything to kind of piggyback on that?
Yeah, and obviously those answers were wonderful. And I think that for me, and to jump off of some of these ideas, but the truth is I don't know what the right answer is, because I know what the right answer might be for myself. And for a new grad, there are a lot of things, like we get caught up, especially in a conference, this is pain science, and this is the way that we do things, and this is how we help people, and this is our most important value. Is it? If you have $60,000 in student loans, is that your most important thing right now? Do you want to be a better clinician? Do you need to pay those loans off first? If you need to do that, then I can't worry about this thing that's a hurdle. I need to worry about this first. And once I get rid of this problem, I can deal with that problem. So the reality is that although we can talk about ideals, and those are important, look, no one is saying the patient is not first and foremost. But if you have to do that assessment of yourself, what can I give up right now, and what can't I give up right now? What's the most important thing to allow me to practice better in the future, in the immediate future, in the long term, and what can't I give up now? For someone that might be, you know what, I don't like the way that they practice, but the patients seem to get better. If it takes them 12 visits versus 8, I can do that. Or maybe I can add some education in and try to assimilate the things that they're doing there, that there may be some value, and work off my loans until I'm ready to say, this was a bad fit, I need to move further, move on to another clinic. Or maybe I need to do that right now. Maybe this is not consistent with my values in any way, and so this was a great job, but not once I got in. So whatever those answers are for you, that's your answer. So it's not a matter of what we think it is. Do your analysis and decide what you think it is, and then you have the right answer.
Ben?
Yeah, I'm just going to kind of agree with Jason. I think you can always learn, easy get out clause, right? I just agree with these lot. No, but I think some of our best learning occurs in bad situations. So if we can appreciate and understand and make sense of the situation we're in and learn from that and grow with that, I think that's often a very powerful place to be. People often get better, and they may get better even though the things that people are doing aren't evidence-based, etc. So what are they doing well? What are these things? I've met some terrible clinicians if you were to look at them in terms of technically. But what do they do well? How they interact, how they deal with people, the care that they get given. So I think we can learn from those aspects as well. It might not be the actual things that they do, but the way that they act. There's some people that you could look at practicing and think, oh, that's in the dark ages, but they have great professional interactions, and maybe we can learn from that.
Right, and I, if I could jump in, because I liked something that you said. No, I did like it, yeah. No,
Did you see that?
But I think, because you're basically referring to a sliding scale, right? Like, what are we talking about? Are we talking about patients are harmed here? Then no one should accept that. But are patients getting perfect care? Just less than that? A little less than that? What is that point where you say this is unacceptable to me? And
Yeah.
Is there something you can learn from otherwise?
And I think sometimes the care that they're getting is amazing, the
Right.
caring. It's maybe
Right.
not always what the technical aspect, it's the caring side of it.
Right.
So we could say the caring is top notch. It doesn't always mean that the clinical skills are top notch.
Right.
But what is most important? There's a
Right.
question.
Right.
And then if I can kind of ask a follow-up question to that, not so much focusing on the patient, but focusing on the clinician. So if you are a new grad or a student, what do you do to protect yourself from falling down that rabbit hole of doing a cookie cutter treatment, or from getting away from maybe things that might be more evidence-based? So what can you do as the clinician to make sure that you're keeping your practice and your career and your goals at top of mind, even though maybe where you're working isn't?
I mean, I still think, even though one of the biggest things I could say is actually things like social media. Because even though you're in a place and working, you still have access to outside influences. And you can still, read new research and keep in with people who are critical thinkers, etc. So I just think keep your horizons open and not just close them off to kind of where you're working.
I do something that I actually learned from my wife, because she coaches a lot of people in achieving success. And what I do is I break down the plan. So I'll ask a patient, maybe they're dealing with a chronic pain condition, and we'll identify things that they value. So I'll say, give me your 5-year goal. In 5 years, what do you want to do? So for the new therapist, that might be, I've moved on to a different clinic, or I've achieved a fellowship, or I've done, gotten a PhD, whatever it is that they want to do. So at 5 years, what's the thing at 1 year that you need to have accomplished in order to see that 5-year goal? They'll give me something else. What's your 6-month goal? What's your 1-month goal, 1-week goal, 1-day goal? And in the clinic, I use that to identify the fact that pain may not actually stop them from achieving these goals. As a clinician, you can use that same type of process to say, okay, I can be here for a year. I can have a goal of paying off my loans or building enough experience to then move on to a better practice. And if you're adherent to your plan, then that takes care of itself. So if you're coming home and saying, wow, that was really cool, and then you look down to your plan and you say, okay, I'm glad that I learned that, but I need to be consistent with my plan. Or I need to change that plan because I've changed my mind, and you have the right to do that. So if you're worried about falling under to some type of influence of poor practice or whatever that might be, then make sure that you don't, by planning, by being proactive rather than reactive.
Anybody?
Generally, I'm really not worried about the people who are curious, which I think connects well with what John was talking about in his presentation. I'm not interested or all that worried about folks who are thinking already carefully about their personal development, thinking already carefully about how they're going to move forward and be patient-centered. I'm really worried about the people who aren't thinking about that. I'm worried about the new grads or students who are convinced that when they have one clinical experience at a shiny place, that they're going to get attached to one particular mode of thinking or one particular system of thought and think that that is the best and only way to do things and become convinced and become devotees of that particular method and have that and fall kind of into that mindset that often happens in medicine that is practitioner-centric, that is expertise-centric, and is not all that focused on personal development, is more focused on what the patient needs to learn from me. And those are the folks that I worry about. So if somebody is out there worried about falling into that trap, those are the kind of people who aren't going to make that misstep in the first place.
Okay, all right. So we'll move on to another scenario, okay? So let's say you're treating or you're working with a fellow healthcare or fitness professional. They have a history of chronic pain. They come to see you, and you kind of explain your care philosophy. You maybe do a session of patient education surrounding pain science, and that person says, well, I just refuse to believe this. If this were true, I would have learned it in school. I didn't. And it's because X, Y, and Z is out of place. Or it's because I pulled XYZ muscle 10 years ago. So now you're talking about someone who is working with you, a colleague, maybe a physician. So how do you approach this person who has, quite honestly, similar background than you do as far as, let's say, education?
So again, I'm in the training realm, but if we're speaking with another professional, maybe it's a physical therapist or a doctor, orthopedic surgeon, or another trainer, again, the answers I'm going to provide, I think, apply to everything. We never ask the fundamental question when there's a disagreement, and I mean an objective disagreement, not, what's better, Hawaiian or pepperoni pizza, right? And it is, we always just throw facts at them, or we just say, well, this is what I do. The question you got to ask them is, okay, you didn't learn that in school, so therefore it can't be true. Okay, what type of evidence could I provide you that might change your mind? Or if it doesn't change your mind, at least create some sort of doubt or some sort of openness where you're willing to rethink your position. And by the way, you have to ask that of yourself, too, when you go to things. Like, what type of evidence would I demand to get me to rethink this a little bit? And that's a really interesting question that nobody ever asked. They just start shooting baskets before they even realize, are we playing basketball or football or hockey here? What's a point, again? So you ask them that, and they kind of go, well, then if in 4 weeks I felt better, or if you could provide me a systematic review, whatever resonates with them. Well, okay, I happen to have one of those. Well, okay, give me 4 or 5 weeks, and let's give this a shot. Are you gonna be all in with me here? Okay, good. Let's go from there. But you have to start off with that question.
Yeah, I always think that minds change slowly. We expect people to have this kind of instant epiphany in front of us where they go, oh, you're so right, I was so wrong. Yeah, this is amazing. Where did I not, And I don't think that it just doesn't happen like that, right? It takes time. And certainly I think the more friction we create with people, the less they want to go along with us. But from my perspective, sometimes you're never going to change it's people's minds. So there is that far side of that aspect as well. But certainly I think that these things need to happen amicably. They sometimes need to happen slowly. And I would always say, why do we not treat them the same way we treat a patient or a client? How would you deal with a patient or a client in this situation? Because they're a professional doesn't mean that their reactions are going to be any different, I would think.
I would also say, to be honest, I don't care what we do. I mean, if my goal is to get the patient better, that patient or that coworker just told me their values. So I can choose to respect their values and to cultivate trust, or I can say, no, I don't do this. So I think a lot of us, I would hope we work with a comparable sign, right? Did it hurt before? I did something. Does it hurt now? Right? So if their methodology works for them, if we do the thing and it works, awesome. And now I've bought trust, I've gained trust, and I have 6 visits, 8 visits, 10 visits, whatever it is that we're going to do. And there are times where I get to try to instill a little bit of curiosity, or I might throw in a little thing. If something that I do works, and they're of a mind to ask that question, then I've gained an opportunity. So I'll do anything. I don't care. It's not, are we labeling? Are we saying this is not something that I will do? Is this not this is something I disagree with? If we disagree with that approach, that technique, whatever, why? I've had patients tell me straight up, I had a patient once, a chronic pain patient, and she was quite sure that she needed this very specific craniosacral therapy from this very specific person in this state. So I said, great, go. Why are you here? Why are you seeing me if I can't deliver this to you? Go. It's not about me being right. It's about them getting better. And if they go and it doesn't work, please come back. But if not, then I help them to achieve their goals, which is to feel better, to move better, to do whatever they needed to. So if that's the person's values, they're stated and they're not willing to budge, then you're either going to have friction or find more opportunity.
Yeah, that's a great scenario. I think the most important thing for me, and something that I've come to realize over the last couple years, is that I just stopped telling people stuff. That's going to require a little bit of unpacking. So I don't ever sit someone down and say, hey, you, this is me, this is my treatment philosophy, this is what, to me, that is starting off on the wrong foot. So I'm interested at first in getting a therapeutic alliance with somebody, and I'm interested in making a little bit of clinical headway with that person in terms of progress. Less pain, less difficulty doing something that they say they wanted to do. And at that point, when you have credibility with someone, when they're moving toward you, you can then begin to have some of these conversations. But kind of a lot of us folks, and I hope we get to this a little bit when we talk about this kind of pain education approach, we spend a lot of time kind of talking at patients and not enough time listening to them and not enough time allowing them to tell us what they'd like to know and then giving that to them when they ask. And in a situation like that, it is much easier to make some of those communication connections. I don't have to convince this orthopedic surgeon patient of mine that his rotator cuff tear maybe doesn't need to be repaired. I don't have to talk that to him. When he stands up off the table and he gets more mobility in his shoulder and he kind of has that aha moment, and I say, well, if this rotator cuff tear was so bad that you needed surgery, would you be able to move your arm like that? And you can sort of see that realization creep over the patient's face, right? That's clinical progress. Now I've established myself as a credible person in that person's life, and I'm credible when delivering that information. And then we can begin to have that discussion. But trying to have that discussion before you've got a therapeutic alliance and before you've got progress toward the patient's goals is exactly the wrong way to go, in my opinion. We need to make those connections and those progress first before we start talking about, hey, this is my clinical approach. This is just kind of goes back to that mindset concept. Hey, I'm the expert. You need to be quiet and listen to me, and let me explain to you why your shoulder hurts. That is the wrong way to go about it, in my opinion.
Were you going to say something?
It's fine.
Okay. I saw you grab the mic. I wasn't sure if you were
not.
going to hop on and...
Jason stole my thunder.
Oh, all right. It happens.
I do that. It's true.
I
happens.
noticed it.
It happens.
You're welcome, Ben.
Thanks.
So let's talk...
Do you see what we did there? We built that.
We've been
there.
working at
That
it,
was
haven't
right-
we?
That happened
We've
right
been
in front
working
of
at
you.
this.
That's how it's done, folks.
Yeah.
Are you getting this? Are you getting this?
Be more like us.
At any rate, so let's, I know we kind of mentioned this whole pain science thing, and oftentimes you hear from people who maybe aren't familiar with it, like, well, it's just talk therapy. You can't talk away pain. You can't talk away, a postural dysfunction or a biomechanical issue. So I guess the first question is do biomechanics count? And if they do, in the realm of, let's say, a movement dysfunction, then how do you weave that in with your biopsychosocial model of care? Nick? This question's for Nick.
Oh, it's for me?
Yeah. I mean, we'll start with you.
Okay. Oh, well, of course it matters. Nobody argues that it doesn't. I think you're bringing this around by the chat that we had outside.
Yeah.
Okay, so
That's
the
right.
reason why she threw this at me is a frustration that everybody's going to have. I might be jumping ahead to something here, and I have reason why I got into training education is because there was the scientists, right? You know, it's training as an art and a science. Same thing with physical therapy, rehab. And you had the science people, and what they did was they talked about studies, and they basically gave you a personal PubMed review. And then you had the artists who were like, oh, screw that, you know, I'm doing this. And it was like these two lanes, and you could either be in one lane or the other. And I was like, this is supposed to be the art of applying the science, which is my little saying, right? So, and there was these two gaps. And then, so what we have now is, again, what you guys seem to have, if you run into the same problems or the same question, faces change, names change, but the same arguments stay the same. Well, what the heck do you do? If you keep having that same problem, it's your fault, because it's the way you're communicating. And that's just one of the same things I do. We're co-authoring a paper for trainers for a peer-reviewed journal for the NSCA. But it's the same thing. Well, I still don't even know. Sometimes I was even listening to, I still don't know what you do, right? So until you demonstrate that, until you start reverse engineering a typical situation, people are always going to think, well, you're saying this is totally doesn't matter at all. So you have to draw the line. Here's where it matters. Here's a situation where it matters to me more than this situation. And if you can provide practical examples, then people can reverse engineer it. So with that little soapbox, what I would say is it certainly matters more to me as you start getting higher and higher loads, because that's where biomechanics is all about, basically optimizing your levers to better deal with loads so you don't exceed the tolerance in one area of the body, right? So that's how I basically tell people, but I don't necessarily use the same strategy just because this is how you want to do a deadlift, or just as how you finish a back row, for how you sit and do text messages with your phone. You know, it's very different. And the analogy that I use, or example, sorry, that I use to demonstrate that to trainers is I'll stand up, and I'll do this at conferences, and I'll stand up and I'll say, now here's how you do, you know, a deadlift, or an RDL, and I'll demonstrate like an RDL position. And then I'll go, excuse me, let me get my water, like this, and I'll go, then all you guys just thought, why is he moving like he's got a pole stuck up his ass? You know? And they go, because movement, how we generally move in low-load, normal functional situations is not how we move under load. So that was a good RDL, imagining the barbell with 200 pounds, but it was a really, you know, Frankenstein-looking pickup of a water bottle, and it actually looks wrong when I do that. So that's kind of how I help them decipher the two and go, oh, okay, that makes sense.
Okay, that does make sense. Ben?
I think biomechanics is like a field of science, so I think it probably matters. You know, it's got its whole, like, you know, there's quite a lot to it. So, you know, biomechanics is quite a big deal. It's kind of how we measure how people move and forces and things like that. So it's a big deal. I think one of the mistakes that we make, though, is always, you know, we forget that human beings are biological. So we have two factors, the mechanical and the biological. And just because you apply a force to a human being, how it responds to that force isn't linear in a biomechanical way. So physics what's physics about? It's about laws. Physics is about cast iron laws, the law of gravity, the law, you know, Newton's 3 laws, etc. What's biology about? It's about variance. You know, when you study biology, you understand about the varied way that things react. So I think sometimes what we try and do is we try and think about the body in a physics way, when actually it's kind of biological. So it has to matter. I just don't know we always know when it should matter. You know, we try and pin that down as these rules and laws, and I don't really think that we've got that understanding yet.
I would say, it's sort of to piggyback with Nick, I would agree with him that as loads increase, we should worry more about the mechanics of a movement. And I think the other side of that is, as the tissue health is a concern, we need to be more concerned about that. A patient with a new rotator cuff primary repair that I'm going to move his shoulder around, that's a situation in which the tissue is at risk, and the mechanics of that movement, I need to be very careful. So I would say as the loads are high and as the tissue health is in question, gives us reason to be extra concerned about the mechanics of that movement. So those are the two kind of little things that I would consider to be important in that realm.
And I think also, I mean, my favorite saying in the clinic is it doesn't matter unless it matters. So, you know, if you do something and it makes a positive change, then something about that, what you did mattered. And to describe it any further, I don't know what changed if I correct a squat position or I move someone's knee in one way versus the other in you know, when they go sit to stand. I don't know what changed. I used the idea of mechanics. Well, why don't we try to move the knee out? Why don't we try to move the knee in? Did that feel better? Oh, it felt better. Cool. Why did that work? I don't know. Right? And that's the reality of it. So biomechanics, I think we get caught up because when we hear that question, we start to think, does biomechanics matter in pain? Like, did it cause pain? Did I move wrong? Did something like that happen? Whereas people that aren't part of this area of knowledge might look at that differently, right? And when we have these arguments about do biomechanics matter, yes, but how? I don't know. I don't know for the person in front of me that came, you know, that's sitting on my table. I don't know. But all I know is that they're here right now, and I don't necessarily have to solve every last piece of the puzzle to get them to feel better, to move better, and to allow them to solve the rest of that puzzle on their own. So if changing a way that they move, telling them, hey, why don't you, press your toe down when you push off in your walk, and they say, wow, my back feels a lot better. How'd you do that? I go, I don't know, magic. And whatever that was, it was. And I don't really get caught up because I feel that when we get caught up in the details from a clinical perspective, we produce our own bias. Well, then that must have worked because I made that change and my thought process was this, therefore my thought process is right. So use the tools that you have at your disposal, and it's science, so use them. But when it comes to the explanation, say, I made a change that appears to be positive for you, positive to your sensitivity, positive to your nervous system, positive to your values, or maybe I got your knee in better alignment, whatever.
I'm going to say something real quick. It's interesting, and he's right. It really comes down to explanations. A lot of these arguments that have been had, it's really just how you explain things. And it was interesting, what I noticed is that when I got into this with trainers is as soon as you would come up and you would say, well, that might not be, that explanation is highly questionable, here's a bunch of evidence to demonstrate that, then they were the first ones to turn around and say, well, everybody's different and everybody needs a unique assessment. You go, well, that's kind of what I'm arguing. Like you were the one who basically said every lordotic, oh, you got a hyperlordosis, well, that's the cause of your back pain. So you made a black and white statement, A equals B, or A means B. And then I went, well, A might not always equal B. And you went, well, yeah, A might not always equal B. I'm like, that's kind of what I was saying here. You know what I mean? So that's an interesting way to kind of circle it around, but it really comes down to the explanations, not getting attached to specific explanations. And by the way, if you want to write articles like I do and some of these guys do, and you want to be less wrong, try to avoid as many explanations as possible and talk more practical. And then in 10 years, you'd be like, oh, I didn't say anything that was wrong. You know what I mean? I just shared what I did.
That's sound advice.
I use that damn strategy, by the way.
We know.
Well, what happens if, this client that you're working with has pathologized what they feel is their biomechanical issue, and then within your explanation, you might have said something that somewhat validated that, and then it just makes it that much harder. Is it? So I guess the question is, how important is it for the patient to not pathologize biomechanics as being the thing that they can or cannot do?
Well, I think it affects their behaviour. And if it affects their behaviour, then I think that's kind of a big deal. So people really, really pick up on that kind of thing very, very quickly. So I think it's a big deal, is the answer to that question, I think. But I think we have to unpick these things quite slowly. You know, again, it's important that we kind of unpick these things quite slowly and we don't attack them full force, you know, and try and be careful with it.
Yeah, I agree. I go out of my way to agree to a point. So if they say, oh, well, you know, I move this way, my back or whatever, I say, you know, that could absolutely be correct. But what's really interesting, assuming this is non-specific, this is whatever, you know, you were probably moving that way the other day before this happened, or you don't remember that instance when it happened, you just started feeling worse. So there was a time where you moved this way and it didn't matter, and there was a time you moved this way and maybe it does. So the secret here is we have two things at play. We have the stuff you're doing and the reaction to the stuff you're doing. And so we can work on both levels. Right? We don't have to just worry about the way you're moving. We can also worry about the way that your nerves are saying, I don't like that. And your brain is going, I agree. And you're feeling your pain from that. So we'll go bottom up, and we're going to do exercises, and we're going to do all kinds of good stuff. But we're going to go top down, too, to settle those nerves down, to say, hey, this doesn't matter. And then it becomes just like a pothole in the street. You don't have to drive over that pothole just because it's there. But right now, you might be. So let's teach you how to drive around it, and then you can take a road trip. It makes sense to them.
I think patients who arrive in your clinic who have a chronic pain problem often have a lot of unhelpful beliefs about their pain. Some of those might be related to pathologizing. And if I'm going to take a patient-centered approach in deciding which of these behaviors and beliefs I want to gently challenge, I need to choose them carefully. I am only interested in changing and challenging gently those beliefs the patient has that lead to maladaptive behaviors. The beliefs that they've got are only important in the extent to which it drives behavior. Beliefs that don't drive behavior, I'm not all that interested in. If I see a patient has got a belief that drives an unhelpful behavior for them, that's something that I'm going to think about using our clinical process to explore and to help give them an alternate explanation if I want the best for them. So instead of me sitting back and going, oh, look at all these ways my patient's wrong, I can't wait to deliver all the good news. They're going to think this is great. My new 23-year-old therapist says my MRI is wrong. Would you believe that? I mean, this is probably not the way to go about it, right? So think carefully about the beliefs and behaviors that you want to challenge with your patients. Do it gently, and do it in a way with an eye toward what their future is going to look like in terms of the way they handle their problem.
So it kind of sounds to me like whether you're speaking with a patient or you're speaking with a colleague and you're trying to get across your point of view, that the easiest way to do that would be to find some common ground. At least that's what I'm hearing from the four of you, is to try to find some common ground in order to, you know, kind of meet that person where they are. So what is a piece of helpful advice for everyone here that they can take home with them, that they can start using, whether it be explaining what we do to a colleague or to a patient, but what is the best way you have found to find common ground to then open the door to having some of those maybe cognitive biases changed?
Actually, you already kind of answered it. I would say I actually recommend them read books about cognitive biases, and I can recommend a few books. I mean, who was it that recommended a couple of books? You recommended a few. I have a few, I would say, really easy reads. One is called How We Know What Isn't So by Thomas Gilovich. Came out in like the late 90s, but, you know, psychology is psychology. It's a really easy, fun read. I would recommend them books. Another one is called Why We Make Mistakes. I can't remember who that was from. It was not to be confused with Mistakes Were Made.
But not by me.
Yeah, and then a fun one that they'll always laugh. You guys will probably laugh at the title. It's called You Are Not So Smart. And the guy has a second book that came out a couple years ago. It's called You Are Now Less Dumb. And I'll ask them just to, hey, check those out, because that's the premise. So if you understand the fallibility of human reason in everyday life and how bad we are at judging the evidence of our own experience, how we misjudge and misremember, then they tend to think, oh, maybe there are other things. And then I told you the question I ask, what would it take to change your mind? There are other things you could ask. If someone's a little bit more scientific, you ask them, how could you be wrong about this? And then the thing is, you could say, well, here's how I could be wrong, right? And then the other way to ask it, which is even more diplomatic, is you just say, what other explanations do you think there could be for that? And it's all Socratic method type stuff. And the last thing I'll just say is that when you're talking about, if you have somebody who's already another therapist who's already kind of entrenched in a view, like Ben was saying, it happens slowly. Instead of saying this is how things are, because those things do change, you just talk about your process. Well, here's why I don't necessarily follow that line of thinking, or here's why I reject that. And if you just talk about it from yourself, it's less pushy, because none of us like being told what's right.
Yeah, I think the idea of presenting an alternative hypothesis is always good. Rather than discounting someone else's hypothesis or belief straight off the bat, present an alternative hypothesis and say that, there's another reason why this might have happened or something like that. And I think that's always quite a nice way. Just you sow seeds of doubt by presenting another alternative, I think. So I'm going to steal Nick's answer a little bit there. That was really easy for me.
Yeah.
I just gave like a 40-minute presentation on this, No, I mean, I think...
It was pretty good.
Yeah, thanks, man. No, I think actually, to some extent, is your own consistency. And again, that was something I felt very strongly about, the idea of saying, we can't control what others do, but would you rather have a beer with a fun person or that jackass in the corner that just always tell me I'm wrong, right? I mean, if we want to compel others to listen to what we have to say, do we listen to what they have to say? Are we kind? Are we fun? Are we people that you want to spend time with and actually want to have a conversation with and let your guard down and maybe learn something? That sort of thing. So if we talk about compelling others or giving information, it's the therapeutic alliance. But that alliance occurs everywhere, interpersonal relationships and coworkers, and you have to be consistent with the values that you want to express. Who do you want to be, and what does that person look like? Then be that person. And it's not a matter so much about the type of, information here, information there. You need useful information, all that stuff. But just be the person you want to be, and if enough people notice that, you'll make enough of a change.
Yeah, that's a great answer. I think if you are being the person that you want to be, people will start to move towards you and ask you for what your take is on something. I think that you really need to wait for people to move toward you to let them know some of what your perspective is. There's a lot of really interesting information about health, medicine, and neuroscience coming out. A lot of it's been reviewed at this conference and others like it. I completely understand the excitement that many people have to go back and just tell other people about this stuff, and that is totally understandable. But that is kind of feeding into that mindset that I kind of talked about before of seeing yourself as some expert who's going to tell other people how the world is. Think of it more about how it can change what you do and how you can go about gently moving in that direction with people. Be less interested in getting across your worldview and more interested in helping your patient or client where they are at that moment. When you have that success, when you have that alliance, when you have that progress, they will move to you and start asking you questions. And that's a much more patient-centered rather than practitioner-centered way to go about it, as I see it.
Yeah, and I would also offer up one more resource for people. So I know Ray was at EP3. Was anyone else here aside from Sandy and Sarah at EP3? Wow, that's great. So one of the speakers at EP3 was Mark Jensen, and he has a book that I can't remember the name of it right now. It could be. Anyway, part of what, I was like, it could be, it sounds familiar. But one of the things that he went over extensively at EP3, and for those of you who are there, you'll probably remember, but it was kind of using reflective language and being able to ask a lot of open-ended questions. And this goes just as well when you're interviewing your patient and when you're speaking to your patient as it does with speaking with a colleague or speaking with someone that, you know, you want them to kind of understand your point of view, but they'll never understand your point of view if you're just ramming it down their throat. Nobody wants to be told you have to, you should, you have to. But instead, if you're reflecting what they're saying and asking them some of the questions like these guys have said, oftentimes they'll come up with that on their own. And you don't have to be the person to kind of ram it down their throat. So I would encourage you to look up work by Mark Jensen because his work at EP3 and his book are really great. So, okay, so we'll have one more question and then we'll kind of open it up for Q&A. So the last question for you guys is, you know, with everything, the couple of scenarios that we spoke about already, is that it can be difficult. It's difficult to share new ideas. It's difficult to get people on board. It's not easy. So, especially when they have very strong-held beliefs. So how do you be more diplomatic with your information when you communicate? So yeah, Jonathan, maybe we'll start with you first because you've really made quite a transformation over the years.
Get on Facebook.
And has become
delete your account.
He has become much more diplomatic. So your advice, I think, will be well received.
It really, I sound like a broken record, but it was realizing that I wasn't being consistent, that the effects that I was having was not consistent with not only the effects that I wanted, but my own self-image. And why was I one way online and another way in person? And what were my goals and my values? And when I had to, you know, kind of sat down and thought about these things, I had to start to face the realization that I you know, I was getting high fives and it was all wonderful and self-motivating, but when I got back to regular clinic work, when I started to really have, you know, more fluid interactions, you realize that you just can't do this. And I've had a few conversations and I think they're interesting. The question was, well, what if I like doing it? What if I like arguing? There are people that are really good at arguing and they enjoy doing it. So do you. But it may not be the best thing if your goal is to try to convince the most people. But if you tell me, well, I don't care about that, then you're consistent. I have nothing to say further from that. If you're okay and you accept the potential consequences of that, do you? But I'm assuming most of us don't. Or do you do that at parties? You know, do you do that at a nice dinner at you know, Thanksgiving? Anything goes in America. But at a dinner party, you know, would you get up and would you slam the table and would you point fingers and would you be nasty, or would you politely disagree, maybe leave the room, you know, something like that? If you're not doing that with the people that you're closest with or that are most important to you, why are you treating others differently? Especially if your goal is to do something like get people more on your side or more, you know, interested in the things that you find valuable. And I think that we do get caught up in the idea of, well, I value this information, so I should be pushing it. If that's the only thing you value, I have no argument. But I'm willing to bet that there are a few other things, and sometimes those values will come into conflict. And when they do, you have to decide for yourself. So if I value kindness, helping others, you know, politeness, I value picking up after my dog, and then I value truth, then do I need to have all of these on the same level? Is there a sliding scale? Or by adhering to these things, I get to adhere to this as well, and I just do a different route? And if you can see that and make that specific to your activities and interactions and belief systems, then you'll be okay.
And so what he's basically saying is another saying that I used to hear was be a lighthouse, not a courthouse. And we're all going to judge, but you decide is what type of person am I going to be in this scenario, right? And am I going to be proud of it? And then you also have to understand this: anytime you are the skeptic, you're the contrarian. and you're coming at it from a scientific perspective. You're already down, you're already way back, because you're going to deal with people who aren't scientifically minded, and scientifically minded takes training. Anecdotal thinking comes naturally. So that's already a problem, right? The language is different. And you're going against something that they have good reasons to believe, or they think are good reasons, right? So that's another argument. We have reasons. This group has reasons. The question is, who has the better reasons, or what are more reliable reasons? That's another discussion. So you're already starting behind, and then you don't want to give them a reason. So here's another reason to be all the things, being diplomatic and Socratic and being nice. Don't just do it for them. Do it for yourself too, because what happens is, as soon as you say anything that's slightly aggressive or show disrespect, you give them an out. Because instead of addressing your arguments, they can just point to you and go, now you're just acting like this, or your tone, you've all heard it before, and it allows them the quick out and allows them to shut you down. So don't just do it, don't give them something to throw back at you. That was actually the start of me being more diplomatic. I was like, well, I'm just giving people an easy out. And as soon as they don't want to hear something, I've just given them an open door to run through, and they'll run right through it fast. So you just don't ever give them that out. And they go, man, like I could, and then they'll think to themselves, there's no way I could have such a diplomatic discussion about such a diverging opinion. But man, this person's really doing this, and it's impressive. You know, and I've definitely had people come around later and say, man, it's pretty cool. I get that a lot, how you handle people. And I don't even get it as much anymore, because I don't argue as much. But it's how you handled it. So that's something to just kind of also keep in mind. And I would also just say, just constantly ask questions to them, you know, and find out, and keep saying, why are you asking so many questions? Well, I don't want to misrepresent what you're saying. That you say, find out, you know, I want to know who you are and why you believe what you believe. And then you build a relationship. And the last thing I'll say is that there's that saying, oh, if you stand by and you what is something about like you can't stand by watching unfairness happen or bad information happen, you know, so it kind of makes us think that we need to be the skeptical warrior and just throw it in other people's face. So, and this is what I call the when science attacks. Remember when animals attack? That nobody is above reproach, so nobody is above scientific questioning when it's about the evidence. However, we forget the opposite end of that no one is below providing respect as a human being, like you would hold the door for them. So you don't have to respect their beliefs, but you have to appreciate and recognize that they're trying. And if you start there, and that's why I see a lot of the arguments, you know, if someone's written 500 articles and they're all blog posts, they haven't got paid for any of those. And you're going to come at them and just talk to them like they're an a-hole? You know, they're trying, and they've contributed the best way they know how, and they're doing it a lot. If you start there and show and recognize that, it goes a long way. And you have to appreciate that anyway, because you certainly want people to appreciate that about you. And we tend to skip over that.
I just wanted to add, you catch more bees with honey. I don't know if that was helpful, but I was so jealous over that lighthouse courthouse thing. And I just wanted to put that in there because that was intense. Yeah, that was profound.
Somebody write that down for John.
But you can also separate the idea from the person.
I think probably the single most thing that helped me the most in this whole process is when I made the shift from being self-centered to being other-centered. Have you ever had a conversation with somebody and it looks like they're not really listening to you? They're just waiting for an opportunity to talk? I'm thinking of like 3 or 4 people right now. That's all, we don't have to get into names, but come find me later. Yeah, come on, man. When you have that kind of orientation, when you have that other-centered orientation, it's less about here's the information I'm going to impart to you, and more listening to them about what they'd like to know and finding ways to introduce that and to offer to help them with that. If you don't know much about motivational interviewing and you're in healthcare or rehab or training, you probably should. And when I started asking my patients if they wanted to know things about a topic before I went into it, I got a lot more interested people who wanted to hear what I had to say. When I said, you know, it's funny because we've been working together for 3 or 4 visits, and clearly your shoulder's doing much better. We've talked before about your MRI. I actually know a lot about, the science of MRIs and how they work and what the health of the rotator cuff is like. Would you like to talk a little bit about that? And what a simple switch, right? Because I would get students in, and their very first visit, they were all about like, oh, here's all the things I want to tell the patient. Like, yeah, remember when I said not to do the thing? You're doing the thing, right? Right? It's not about telling people stuff. It's not about telling people stuff. It's not about getting across what you want to get across. It's about finding out what they want to hear. And there's a huge difference between those two.
Yeah, I think Jason, again, stole my thunder just a little bit. He keeps doing that. Yeah, I think the point is when we are looking to give information, we have to ask ourselves, what's the aim of it? Is it to tell someone else what we know, how much we know, make ourselves look right? Or is it about trying to help them? So I know, in a lot of arguments, two people are trying to show each other how much they know in the guise of trying to change someone else's mind. But often it's, you think if you become a little bit more self-reflective, perhaps you have to ask yourself, why are you giving this information and why are you giving it so aggressively? What are you trying to prove? Is it about trying to help someone else, or is it about about you?
Okay, so we'll open it up for a
I just
couple
want to
of
add
questions.
one thing real quick. Just
in
ask
a
people,
second.
are you interested in hearing this perspective? Are you interested? That's always a great way to just preface before you add anything.
Okay, so if you have a question, just raise your hand. Oh, great. More than I thought. Good job, guys. Great.
Hi, I would like to know,
Hold the grenade.
Boys.
I would like to know a little bit more. Motivational interviewing is something that I really haven't been exposed to much, and this idea of asking them questions to do it. And I was just wondering what resources there were out there for it, because it's something I definitely need to change. I tend to just talk neuroscience to people, and it works sometimes to a degree, but not as well as I'd like it to.
Yeah, as Dr. Phil used to say, how's that working out for you, right? I found it, for me, it wasn't working out too good, right? Well, I will tell you, I read the latest edition of the motivational interviewing textbook, but I read it while I was in Afghanistan, and I had a little bit of time on my hands, and some things I'd like to get my mind off of. So it is a very thick book, and I think it was great, but it maybe isn't as accessible. There's a different version called Motivational Interviewing in Healthcare that I've started through that I really enjoy a lot. I haven't completed it. There's also a series of video clips on motivational interviewing on YouTube, and I got a playlist on my YouTube channel that will help you find that motivational interviewing piece. And I don't know if the other group
And
has got.
I would also say to go to Bronnie Thompson's blog. It is chock full of great resources and information on motivational interviewing, amongst a lot of other things. So definitely check out Bronnie Thompson's blog, because I think it's great.
And I think for anyone that saw Professor O'Sullivan in the pre-conference, that he put on clinics of motivational interviewing, where the goal is to gain. I mean, essentially, it's to get information, but as they express it to you. So you're asking open-ended questions. You're following their words, and you're seeing where it leads to, and then you're gently kind of guiding into different areas as they're exposing it, or as you feel that there's something that's being kind of hidden away, perhaps. So it's not so much about, so tell me the first time you had your pain. It's, so tell me about yourself. And it's allowing the person that you're talking to sort of guide their thoughts while you steer where those thoughts are directed next, kind of thing. So.
Yeah, and I would also add, and I think Sandy Hilton can probably attest to this as well, but if you're kind of thinking a little outside of the box, if you have access to any sort of like improv classes or things like that, I would highly suggest taking one, even if it's just an intro to improv, because what it will help you do is it will help you to listen to someone, which is the most important part about motivational interviewing. It teaches you to listen to someone and at the same time be able to be quick enough to formulate a thought in your head as to where you're going to go next, and also teaches you how to reflect back what they're saying in a very easy way. So if you have access to any sort of, and Sandy, is there any books? I know UCB has a book, but does... Yeah, I'm not sure. But if you have that and you want to, it might be a little less expensive, and most places, even if you're, I mean, I'm in New York City, so obviously there's a lot of resources, but I think anywhere in the world you can find a resource for an improv class. So that's a kind of another way to get you to think a little bit faster on your feet and to apply a lot of motivational interviewing principles with a lot of practice. Okay, question.
So my question is going to be heavily biased from my perspective. So it's obvious that with all these communication strategies and the emphasis on the patient story and being the patient demo for Peter O'Sullivan and him starting with tell me your story and how powerful and stuff that is, and then Jason saying how important it is to find out what the patient wants to hear. How do we do that better in a professional setting to actually find out what patients want to hear and what they find valuable from treatment, rather than just in that one-on-one setting, having it more a part of professional training as well?
Well, I mean, I think that's the million-dollar question, right? It's not so much how to change a couple of people here and there at a conference. It's how do you begin to turn the wheels that will change professional education across professions. And if you're sitting in this room, that's now your job. So you have now been challenged. Jolette has challenged you, and please rise to her challenge. Get involved with teaching students. Get involved with speaking in the community. And I know that there are some academics here. There are some academics at other conferences that we go to that talk about this material, that popularize it. And that's really the direction we need to go. We need to get it into the curriculum, both clinical and academic, of our programs.
And I would also try and put some pressure, I know, at least for PTs, to CAPT and to the national exams, to make it part of the national exam, because oftentimes if it's not, students are not taught that. I don't know how many PT students or massage students are in the room here, but if it's not on the exam, oftentimes it's not taught.
Yeah, and that's exactly right. I mean, I think that we could have an entire discussion of the education process and what is deemed relevant and important. But in fairness to the education process, it's also a matter of saying, producing clinicians that aren't harmful versus producing experts. And I mean, we can have debate of that too, but there is, to some extent, there's a little bit of understanding, like, all right, I may not agree with that, or maybe I do, but I think that a lot of these techniques should be part of education because it is the patient interaction. And I'm sure everyone, any therapist here or whatnot, we got that patient, education course. And it's not like anything we're talking about. And students struggle with that. New clinicians struggle with that. Old clinicians struggle with that because we're not really taught that. We're taught the biomechanics and the muscles and the anatomy and the nerves and the bones, but we're not taught the lungs and the voice. So that's a major problem.
My question is sort of actually maybe looking for a little bit of advice, because as a massage therapist, a lot of times it feels like I'm fighting an uphill battle. When I get patients that come in because they've gone to their doctor, they've gone to a physiotherapist, they've gone to a chiropractor who have more education than us, and then they come in and say, oh, my chiro said I'm out 4 degrees here, 10 degrees here, and 4 degrees here. And then you give them a treatment to try to get them away from that, and then the next week they go back to the chiro or the physio or whoever that tells them the same thing, and they keep reinforcing it before you have a chance to start to shape that again. So would you guys have any advice in how to start handling that, especially with patients in recent traumatic injuries like car accidents and things like that?
Play the long game. I mean, you're not going to confront that on day one. You're not going to change that mind on day two. But is it useful? Is the information you provide useful? Is the treatment you provide useful? If and when it is, and they develop that curiosity, you can start to suggest kindly that, you know what, that may be true, but I don't know if that's important to you right now. Or ask them, like Jason said, I think you did really well. I'd love to talk to you about maybe why, if you'd like to know. So you're developing that trust. Because you're right, there is hierarchy in medical field, practice, anything in the continuum. And to try to subvert that hierarchy can be unsettling at best to patients and at worst get you cutoff sources for referral, and I would put out there that what's more important in the end of the day, that you receive referral or receive patients or clients, or cut those right off. So I'd rather work with someone that doesn't agree with me at all and still receive the opportunity to care for their patients than have no opportunity to care for their patients. So if I have to correct every single time, then I have to do that, and so be it. But it's better that I at least have that opportunity and that contact. So be an expert. Be the person that gets their patients better. Be the person that gets your clients better. Do everything you can to be better. And when you do that, people take notice. So even if they're, make your reputation greater than theirs from that perspective. So they could go to any medical doctor, any physical therapist, whatever it is, but their friend or their family member said, no, I've got someone that you need to see. That's power too. And it's important.
See, Marcus Aurelius said about 2,000 years ago, it is silly to try to escape the faults of others. They are inescapable. Just try to escape your own. I think the best advice for you is to try to be who you are and to try to create some of that experiential learning with your patient on your massage therapy table or in your clinic. And think to yourself, what are the most important beliefs my patient has that are clearly unhelpful to their health? So that's being other-centered. How can I use my treatment to gently explore those beliefs and provide some disconfirming evidence? Because evidence is always more important than what people say. Even in a situation where you're dealing with people who have more cultural authority than you. In medicine, often the people who have the most cultural authority have the least expertise. Anybody else notice that? That's a problem, isn't it? Right? But so if you feel like you don't have the cultural authority with that patient, you don't need that authority if you can provide them some experience that contradicts some of those unhelpful beliefs. And when that happens, you can be other-centered and engage with them on some of those topics as the opportunity presents itself.
Okay, and we have time for one more question right here. And then for everyone whose questions because got to wrap it up.
I'm hungry. I need dinner.
Yeah, you don't want him to get hangry.
Hangry.
So if you have any questions, you can Facebook them. No, you can come up afterwards really quick. So go ahead.
Okay, mine's not so much a question as addressing that first question that you presented from a massage therapy standpoint. When I was a new therapist, I was working in a spa. Everything was very relaxation focused. They didn't want you doing a lot of therapy, a lot of pokey stuff. And a friend gave me some awesome advice. It was, you can give them the box, but you don't have to get in the box. So what I did was I learned on my own kind of how to integrate some therapeutic work into that relaxation massage. And once I got good with that, so that basically that meant not a lot of the pokey stuff, no trigger point therapy. And when I got good with that, and I got a little more comfortable doing that, I started asking my clients, well, what's your priority for this session? And the ones who had come in with pain, funnily enough, their priority was, I want to be out of pain. And so I would still do the full body massage, but we would spend some focused time just doing actual therapy, and then I could do some of the more pokey stuff just in that area and still get the full body. So I gave them their box, but I didn't get in the box.
And I was going to add too, and for the massage therapists, I mean, we're kind of biased up here and whatnot, but the massage therapists, the trainers, I can't tell you how many times I've had a patient come in and say, well, my massage therapist said this, my personal trainer said that. And it's not just my medical doctor said this or the diagnosis was that. And what they're telling you is not this person above you. What they're saying is this person I trust gave me this information. Can I trust you? That's what they're saying. So there is a hierarchy because if we don't know, I just showed up at the doc, so I guess they're smart. We have assumptions. But the truth is the information they tell you is information they trust, or maybe there's some question to it. Maybe they don't trust it, but you don't know unless you ask. So if they say, oh, well, so-and-so said this, the next question is, what do you think about that? Does that seem right to you? And if they say, well, yeah, I just wanted you to explain it. Okay. And then you can explain that because you'll break their trust if you don't. But if they say, I don't know, it just doesn't seem right. I've used the example of, you had this pain today, but you didn't have it yesterday. So if the disc was an issue, why do you think that happened? They'll go, I was thinking the same thing. They didn't ask it because they were afraid to, because they thought they were wrong. So give them that voice, listen to what they're telling you, and hear what they're saying.
Okay. Yeah.
Provide just a piece of advice. Whether you've had discussions with other professionals, debates, disagreements, at whatever cordial or non-cordial level they may have been, and you also deal with patients, you probably heard the same reasons for things that they've given you why they don't agree with you or why they believe some other practitioner who you think is giving them questionable advice. So even if you don't write a blog, have no desire to write blogs or do videos like some of the people here do, my suggestion to you is take time to provide your best answer, your default answer to your most common questions, common concerns, common rebuttals that you have, or common rationale people provide that you don't think is good. Because if you don't, people are used to hearing something that sounds reasonable. For example, well, that coach has trained 10 Olympians, right? And who have you trained? Or who have you rehabbed? So that sounds pretty damn reasonable to most people. So if you can come back and you go, well, are you claiming that every Olympic coach does the exact same thing, that they all agree? Well, of course not. Okay, well, that's not good enough then, because the next Olympic coach is going to say something completely different. So clearly that's not a good enough reason. Then if you can come back at them sometimes, and this is not argumentative, and you get them to go, oh, sometimes you create that openness. Oh, okay. Maybe that's not a good enough reason. Again, it has to be done diplomatically, but spend time, and it's a real pain to think about that, because you'll rack your brains. It all sounds like but if you don't have good replies that sound just as good as the reasons that they're giving, you're not going to get that far. They just think, well, I won. I did the mic drop on you. If you can hit them with another mic drop, then they go, wait a minute now. It's not as strong of an argument as I thought. And that takes a lot of time. But spend time thinking about that. It's well worth it. And then you just have that default quick right back at them.
Okay. All right. Well, thank you to all of you guys for being on the panel. Let's give a big round of applause for all of them.